Hello everyone, this is Muriel Kameni. Welcome back to this fourth lecture video where my partners Marie and Benson are going to be covering epidural placement and medication. So just a little bit of a recap of what we did last time. We spoke about the midline approach versus the paramedium approach. So with the midline approach, you want to make sure that you pretty much cover all the different layers going from the skin all the way to the ligamentum flavum and then straight to the dura, versus the paramedium approach where you have to go pretty much lateral either from the right or the left side, and then you're going to bypass the supraspinous process and the interspinous process, hit the ligamentum flavum, and then get into your epidural space. So over here, we're just going to go in detail about the different steps to take in order to put an epidural placement. So the first thing, obviously, you want to do is to do a TAMA. You want to verify your patient identity, the procedure, and the consent. You're going to verify your epidural kit, make sure you have sterile and non-sterile glove, and also a cleansing solution such as chlorhexidine. You're going to place your patient either in a sitting or lateral position, apply your blood pressure cuff, your pulse oximeter. You're going to go ahead and initiate an IV fluid bolus, because typically with that epidural, the patient will be quite vasodilated. So you want to go ahead and start giving her fluid. You're going to wash your hands, apply your hat, your mask, your eye protection, and non-sterile glove. And then you're going to go ahead and palpate your iliac crest so you can locate your landmark, typically around your L3 or L4 or L4, L5 interspace. And you can go ahead and make an indentation there so you remember where you're going to put your needle. So then you're going to go ahead and clean the skin in a circular motion. Then open your epidural tray before placing your sterile glove. After that, you're gonna go ahead and put your sterile glove using the proper sterile technique. Then apply the sterile drape. You're gonna then verify the content of your anesthetic before drawing it up. So the first thing typically would be the 1% lidocaine. You're gonna use a 3C syringe to draw that lidocaine, and then make a skin wheel to kind of numb the area before you're going to insert the needle. So then you're going to insert your epidural needle, go into the different ligament, and once you hit that, once you go to those different ligament, you're going to then remove the stylet. And after that, you're going to go ahead and attach the syringe to make sure that you check for loss of resistance. So you can either use air or use normal saline, or sometimes people actually do both. They will start with the air and then go ahead just to be sure they will put the normal saline in. So like I mentioned earlier, you're gonna go to the different ligament, and then once you hit like your ligamentum flavum, you're gonna go ahead and you're gonna push that saline or that normal saline till you lose your loss of resistance. So when you go ahead and you get that loss of resistance, you want to make sure you remember that number. You're going to then thread your catheter. Usually you want to thread between 3 to 5, no more than that, because it can migrate and be unilateral, and you won't be able to have a good epidural block. So then you're going to go ahead and remove the catheter and place the port at the end of the catheter. Check for aspiration. Make sure that you aspirate, and then go ahead and secure your dressing. So after you do that, you want to go ahead and do a test dose. The test dose is to make sure that you're not intravascular or intrathecal. So you're going to go ahead and aspirate, and then inject 3 cc or 1.5 Lido with epi. And so if it's intrathecal, then the patient will not be able to move her leg. Or you're going to ask the patient, are you able to move your leg? Or if it's intravascular, you're going to start seeing an increase in your heart rate. You're going to ask your patient, are you having anything in the ear or any numbness or metallic taste? That will tell you that the patient that will tell you that the catheter is intravascular. However, if the test dose is negative, you're going to go ahead and secure the catheter and put the patient in a left uterine displacement position so that it can help with the blood pressure. And then you will go ahead and you administer 5 to 15 ml of your local anesthetic, and then monitor your patient every 2 to 3 minutes blood pressure and make sure the woman remains hemodynamically stable. And then you're going to go ahead and assess your pain score and assess the extent of your sensory block, if it's either cephalad or coda, and then after that, initiate the maintenance of your epidural analgesia. And then on the next slide, so one of the advantages of having an epidural is the fact that if there's any emergency, you can convert it to an emergency section. So with epidural for labor analgesia, usually the extension, it go up to like T10 level. But for a C-section, you want to make sure you go up to T4 level. So you have to give a higher percentage of the local anesthetic, typically lidocaine 2%. So you give about 5 to 10 ml bottles of the lidocaine 2% with epi. But prior to giving that, you want to always make sure that you aspirate to make sure that you're in the epidural space. You want to make sure that you're not in the intrathecal or intravascular, giving a total of 5 to 10 cc at a time. And after that, assess for your sensory or your motor blockade after you transfer the patient in the OR. And on the next slide, it's just a picture of that pretty much kind of summarize your step of inserting an epidural needle. So on the upper left corner, you see how they're advancing the cherry needle. And once you're in the epidural space, after checking your loss of resistance, you go ahead and you send your catheter, and after that, you can go ahead and give your lidocaine, I mean, not your lidocaine, but your local anesthetic of choice. And so the next section will be covered by Benson.
Hello, everyone, and welcome again to, I will continue on the different type of medications that we'll be using for our labor epidural. And on this slide, I'm going to start by for us to look at what are the choices of drugs that we have and how do we make those choices. So first, we want medication that are very ideal for the effect that we want to achieve. And we want a drug that is supposed to have a rapid onset of action, a drug with minimal motor block, drug with less maternal toxicity, a drug that has less effect on uterine activity and the uteroplacenta perfusion. And the last and not the least, a drug that have very little effect on the fetus. Looking at the choices that we are making, it is hard to believe that we can have a drug that is that ideal, because some drugs will be good for the fact that it spares the motor, but at the same time the drug might be a little bit cardiotoxic or cause more maternal toxicity. So the first drug we're looking here is Bupivocaine. Bupivocaine, as we know, is an amide local anesthetic agent with high potent binding capabilities, which means that drug can easily be transferred over the placenta. We're using Bupivocaine 10 to 20 mils of our 0.0625%. 0.0625% is 0.625 milligram per mil. And we're going to use 5 to 10 mils of that concentration. Bupivocaine 10 to 20 mils of our 0.0625%. 0.0625% is 0.625 milligram per mil. And we're going to use 5 to 10 mils of that concentration. The subsequent slides, you will get into details to see how the calculations are done so that at your different places, you can be able to dilute them to that concentration. At the same time, when we're using Bupivocaine, we can add fentanyl into our Bupivocaine, and we'll be using, for label epidural, we're going to be using 0.125% combined with fentanyl to initiate our label analgesia. And just to make us know here that the concentration of fentanyl we are going to be using for epidural is a little bit higher than if you are doing a spinal, which I don't want to, I'm going to eat here. But when you do an epidural, for instance, you can use up to about 50 to 100 mics of fentanyl. That concentration should be able to relieve pain within 8 to 10 minutes. It peaks at 20 minutes intervals, and the duration of action is 90 minutes. However, there should be bolusing potentials along the line. If a patient gets pains, if you have a breakthrough pain, the patient has a potential, or we can always bolus it if you were the one actually doing the bolusing. But in places that have like epidural pumps and the rest, the patient has that potential possibilities of actually bolusing the drug by herself. The second drug we are looking at here will be Rupivocaine. Rupivocaine, again, is an amide local anesthetic. However, the advantage of Rupivocaine over Bupivocaine is that Rupivocaine has less motor block effect. And so that drug, and less cardiotoxic effect. So Rupivocaine seems to be the best drug that people are using in a lot of places nowadays. However, if you don't have Rupivocaine, you would therefore have to go with your Bupivocaine, which I think is what is very available in the Cameroon context. So the advantage, I've said, of Rupivocaine is that it's going to be cleared rapidly than Bupivocaine. So even if you had, for instance, like a rapid absorption of Rupivocaine into the system, the rate at which is going to be cleared will be faster than when you have like Bupivocaine. And that is one of the reasons why Bupivocaine is highly proton bound, but Rupivocaine is not. So the faster rate of clearance of Rupivocaine is equally due to that effect of proton binding. It's less cardiotoxic, it has less motor block, and can be combined with fentanyl for labor analgesia. The third drug that we're looking at, which we can use for our epidural analgesia, is Lidocaine. It is still an amide local anesthetic, but it has an intermediate duration of action. However, because of its short duration of, because of that short duration of action, Lidocaine is not commonly used for labor analgesia. However, we commonly see it if you were to convert your labor analgesia into an anesthetic concentration. If we had an emergency and we are converting our labor and epidural into a C-section case, you can top that epidural that you had in place with Lidocaine. And again, the concentration and the amount will be detailed in the next subsequent slides. Beside our local anesthetic agents, one of the group of drugs that goes along with it is opioids. And the advantage of opioids is that it enhances the pain effect of your local anesthetic agent because it's able to bind to the pain receptors in our spinal cord and our substantia gelatinosa. So the first drug we are using here is fentanyl. Fentanyl is a highly lipid soluble agent. It has a rapid onset of action. It is short duration of action, 20 to 30 minutes, fentanyl is out of the system. It has a greater systemic absorption effect, moderate analgesic effect in early labor, but decreases Bupivocaine requirements. So if we are using Bupivocaine, and we are using fentanyl alongside with Bupivocaine, we can therefore reduce the amount of Bupivocaine that we are using because fentanyl can potentiate the effect of Bupivocaine.
So we will be looking at medications for epidurals. This table just gives us a rough overview of the drugs, the initiation dose and the maintenance dose. So like Benjamin talked about the local anesthetics, Bupivocaine, Lidocaine. So if you're using Bupivocaine, the dose for initiation will be 0.625 or 1.25 milligrams, which can be 0.0625% or 0.125%. In the later slides, I will show you guys how we got to the conversion from percentage to milligram. The maintenance dose will be 0.5 to 1.25 milligrams or 0.05 to 0.25. So for Rupivocan, the initiation dose is 0.8 to 2 milligrams, and the maintenance dose is 0.08 to 0.2%, which is the same for the maintenance dose. Lidocaine, like Benson said, we don't really use lidocaine a lot for epidurals. We use lidocaine in case we need to get a very dense block for C-sections. But in case you have to use lidocaine, you can use 7.5 to 10 milligrams for initiation dose, which is 0.75 to 1%. And maintenance dose will be 5 to 10 milligrams, which is 0.5 to 1.0%. But normally for epidural anesthesia, for C-sections, we use 2% of lidocaine. For fentanyl, we have 50 to 100 mics, and maintenance dose can be 1.5 to 3 mics per ml. So how do we calculate our local anesthetic? So the first example we'll be using will be Bupivocaine, also known as Macan. So if we have 0.5%, that equates to 5 milligrams. So I always think about it in my head. If I have a percentage, I just move the decimal place 1 to the right. So that's how I got my 5 milligrams. And in order for us to calculate, like for example, we want 12.5 milligrams of Bupivocaine, and so we have to calculate it based on cc. So we know if we have 2.5 cc, and we know that 5 milligram is in 1 cc, we just take 5 milligrams times 2.5 cc's, and we get 12.5 milligrams. So you'll be having 12.5 milligrams in 2.5 cc of Bupivocaine. And then we have to know if we're giving a 20 cc bolus and we only need 2.5 cc, we have to subtract that, and the remainder, which is 17.5 cc, is going to be normal saline to help push it into the epidural space. And at the bottom one, it also shows us how to calculate it. So if you do the calculation and you want to get 0.625 milligrams per cc, like I said earlier, if you're using a 5.5% of Bupivocaine, which is 5 milligrams per ml, and so a dose that we want as a total is 12.5 milligrams, which is 2.5 cc. We already know a dose for the 2.5 cc, which is 12.5 milligrams. And when we have in a 20 cc syringe, that will give us a dose of 0.625 milligrams per cc. And if you want to, like I said, make sure it's the right dose, we can always say 0.625 milligrams times 20 cc will give us 12.5 milligrams. So these are two different ways to calculate it, like we explained earlier. So you can only, whichever way is simple, just familiarize yourself with, whichever makes sense in your head. You already know, if you know you have 5 milligrams and the dose you want to give total is 12.5, you can just say, okay, 12.5 divided by 5, and I'll get 2.5 cc's, and then I have to add a remainder. I have to subtract from 20 cc's, and my remainder is going to be what I will use of normal saline. So when we use another dilution equation for lidocaine, so 2% of lidocaine, like I said, move the decimal place to the right, and that will give us 20 milligrams per cc. So if we take out 5 cc's, which is going to be 5 times 20 milligrams. That's going to give us 100 milligrams. So 5 cc's is 100 milligrams. And then we want to add 5 cc of sterile water to it. And so this will be 100 milligrams divided by 10 cc. So we have 10 milligrams per cc. So for labor analgesia and intermittent bolus lidocaine, you can either do 7.5 milligrams or 10 milligrams. That's how we showed you guys how to do the 10 milligrams. Like I said, you always want to make sure whenever you do your math, you always double check to make sure it's the right concentration, because we don't want to make any errors while doing this. We don't want a denser block at all. So feel free to always use your calculator. And I will give you 2 equations that you can utilize to make sure you get it right. So we will be talking about the side effects of opioids. One of the 4 major side effects that this patient witnesses is pruritus, which is just another way for saying itching. They can experience nausea, respiratory depression, and urinary retention. So the number one thing is always the itching, and you have to, you can give Benadryl, sometimes that help, but that will make the patient sleepy. And it has been noted that the only way for them not to experience pruritus is to give Narcan, and we don't really want them to have the analgesia. And respiratory depression is mostly seen with the hydrophilic opioids like Duromorph and all of that stuff. The urinary retention can occur, but most of these patients will have a Foley when you're placing an epidural as well. They have nausea, but they can always get some Zofran for nausea. And lastly, we'll be talking about the intermittent bolus technique. So you want to give your intermittent therapeutic bolus when the patient begins to feel pain. So you always want to determine what stage of labor the patient is in. And you always want to determine like the essential blood before you administer another epidural bolus. So when you're administering, you want to give around 8 to 10 mL of local anesthetic combination with the opioid solution to reestablish your analgesia. And you can give it, like we were always explaining earlier, you always want to aspirate before you give any bolus. So you aspirate, make sure there's no CSF, make sure there's no blood. And then if you want to, you can give like 5 cc increments until you get the total dose that you want, which is going to be 8 to 12 mL. You always want to monitor your central level, your motor blockade, and you want to assess this before and after every bolus. Like we said, this is for pain management, for labor. We don't want to have anesthesia dosing. So we only want this to cover up to T10. We don't want it up to T4. And one of the disadvantages of using the intermittent bolus is like they don't get a steady concentration of the medication. So that's where we have to always bolus it. So whatever local anesthetic we give, we have the duration of how long it's going to last. So you want to keep that in mind, because if it's going to last like 90 minutes, you want to know roughly around 60 to 90 minutes, you want to check up on your patient, and you also want to bolus them as well. All right, well, thank you guys for listening. And that concludes our current education session on epidural placement and their medications. If you guys have any questions, feel free to drop it on the comment section. You can also send us a message on WhatsApp. The calculation is a little bit difficult, so we will recommend you guys to try to calculate it by yourself to get an understanding of it. If you guys have any questions, we're more than likely to go over it one more time with you guys, okay? All right, thank you once more and have a good day.